Great to have you with us on WPR News. Larry Mueller here, starting the show today to talk about mental health and focusing on why exercise is so important to your mental health. Back with us, Dr. Shilagh Mirgain, distinguished psychologist in the Department of Orthopedics and Rehabilitation at the UW School of Medicine and Public Health. She specializes in using mind-body medicine to treat mood and anxiety disorders, injury rehabilitation, and more in athletes. Dr. Mirgain is also a sports psychologist to UW Badger student athletes. So as we talk with her, I hope you'll join in with your own thoughts. Tell us how exercising maybe has changed your life. How do you move your body when you want to feel happier? You can share your favorite exercise that helps you feel at peace, or maybe you have a question, and I hope you'll join in. Number to call, 800-642-1234. It's 1-800-642-1234, or send an email to talk@wpr.org. Dr. Shilagh Mirgain, welcome back. Good to have you with us.
Thanks for having me, Larry.
Exercise has many benefits, but what are some of the biggest benefits for our mind?
This is such an important topic and one near and dear to my heart because one of my goals this summer is to get out walking during my lunch hour. As a busy mom to a 3-year-old, I've often focused on her sporting events, and some of my own fitness goals have gone on the back burner. So the research is really strong. There have been thousands of studies that have shown that there is benefit to exercise to both physical and mental health. In particular, for mental health, we find that people who are regularly exercising can experience a reduction in depression, anxiety, and stress. There can be benefits with symptoms related to ADHD and even trauma. And I think a really important point is regular exercise is important, and getting a reasonable amount of exercise during that time, a reasonable amount of minutes exercising. But research shows that even 20 minutes most days of the week can have significant benefit to your overall mental health. And lastly, we do find exercise, research has found, can be as effective as medication and psychotherapy for mild to moderate symptoms of something like depression or anxiety. So really, movement and exercise really is medicine for our body.
What's the research show about the connection between our brain and exercise? What goes on in the brain when we're exercising?
It's such a great question. We know that a couple things are beneficial. So our body does produce natural endorphins when we are exercising, those kind of feel-good hormones. We also know that because we are expending energy, we often sleep better at night and have sharper memories and can relax more deeply. We also know that with exercise, sometimes there's a social benefit, like if you're in a class or walking with a friend, or simply just walking in your neighborhood saying hi to people. And I think from a mindfulness perspective, it allows us to connect with the outside world if we're exercising outside. And so I think it helps us get out of ourselves, get out of our thinking, and engage more with the world around us.
I know that in the mornings, I'm out there at about 5:30 in the morning, and I see kind of the same people. I always say hi to everybody, and they usually say hi back. And most of the time, they're in pairs. I'm by myself, and there's a few singles out there that are walking, but we always say hi, and it kind of feels good to do that.
That little bit of engagement can produce what's called a micro boost, just a little boost in mood and energy that can really set the tone for your day and carry through with you throughout the course of the week.
Yeah, Scott in Hayward has a comment or question. Let's go there. Hi, Scott.
Hi. I have exercised most of my life, adult life, and I really enjoy it, and I definitely agree that it has helped my mental acuity. I noticed in my early 70s that I developed a kind of a groundless anxiety. Wondered what the heck was going on. I went to counseling, and they encouraged me to journal, and that helped. And by the way, I bike, ski, and used to run. I really miss that, but I can't do that anymore. So anyhow, what has really helped me lately is I have gotten into what's called intentional cold immersion. I use a cold shower at the end of my shower, and that seems to have really just taken away that anxiety that used to bug me so much.
Interesting. What do you think, Shilagh?
I think that's really inspiring. Number one, you've tried different forms of exercise, and sometimes for particular seasons of life, we might be a runner, but then we become a cycler, or then maybe later in life we go to the warm water pool. And I really can't speak to the cold therapy, but I do know many people would really swear by it, whether it's a cold plunge or a cold shower, just to really revitalize the system. So that might be something people could try as well.
Yeah. Scott, thanks very much for sharing that. Appreciate it. Let's go to Iris in Viroqua. Hi, Iris.
Hi, I'm so glad you were able to take my call. So I have a very physical job. I have a house cleaning business, and I average 3 to 5 miles of walking a day through work. And I'm wondering if you see the health benefits only in like specific exercise, or do you see those benefits in people that have physical jobs and are just moving a lot in their day? And I can take my comment off the air.
Yeah, interesting question, Iris. Thanks for calling. What do you think, Shilagh?
Yeah, that's really inspiring. So research shows walking in whatever form can be really an effective treatment for depression. It can be protective with our mental health and making it less likely for depression to occur. And many people wear pedometers to just track their steps. And, like you, we might be walking more than we realize, or maybe it inspires us to park further away when we're getting our groceries so we can have more steps. Or in the winter, maybe we do one more loop around that big box store just to get in those steps. We also find jogging, yoga, strength training to also be more effective than other exercises, particularly when intense. So there's probably a way when we're walking, we could go really slowly, or maybe we just pick it up, the pace up a little bit just to really get our cardiovascular system more engaged. So, and I think your point is so powerful because we don't have to buy all the fancy clothes, get the gym membership, get the gear to start an exercise program, that it can be as easy as just maybe doing a few more laps at work, for example, during our workday.
So in her situation, she was wondering, I think, I'm already doing 3 to 5 miles a day, but that's part of my work. So would it be, do I need to do more outside of the work situation for my mind and body?
Not necessarily, because one of the risks is overtraining, overdoing. 3 to 5 miles sounds like that's probably plenty. Do you need to go out for a walk when you get home? Probably not. But maybe there is another form of exercise that you want to do, like a gentle stretching class or getting into the pool and doing some swimming that would allow some cross-training.
Yeah, that makes sense. Thanks very much for that call. You can join in, too. Number to call, 800-642-1234. Or you can email to talk@wpr.org. I'm Larry Mealer with my guest, Dr. Shilagh Mirgain, here on WPR News. Talking today with Dr. Shilagh Mirgain, and we're looking at the benefits of exercise for our mental health as well as our physical health, but zeroing in on the mental side of things. Are you having trouble getting started in an exercise program? That may be a question you might have for our guest today, and you could join in at 800-642 1234 or email to talk@wpr.org. Well, unlike our last caller, Iris, most of us, or many of us, let's put it that way, spend a lot of time at work just sitting on our butts, to be perfectly
Absolutely.
honest.
Yeah, and we often talk about sitting as the new smoking, that becoming too sedentary can be more detrimental to our health than smoking is. And I think, right, many of us have desk jobs or we've just become too sedentary. And like Iris, just even getting up, the recommendation every hour for sitting to get up and walk or move for 2 to 5 minutes can have good cardiovascular benefits.
Yeah, I think that's true. Well, there are people that don't necessarily have a great attitude about exercise. Let's put it that way. I kind of like it. I got used to it. I just don't even think much about it anymore. I just get up and do it, and I feel better when I'm done. But how do you change your attitude about exercise?
Larry, and you're such a role model, and just what you shared, that you changed your attitude about it, that you feel good after, and you just get up and do it. So I think there are 3 important things there. First is revising your attitude or mental script. For some people, exercise had a negative association. Maybe you were the last person to get picked in gym class, or maybe you got teased, or didn't feel good enough in your teen years for the ways you engaged in sports. I think it can be hard to get back into exercise when we've stopped. Kind of like physics, a ball that's stationary, it takes a lot of energy to get it moving, but once it's in motion, it takes a lot less energy. So I think a really important point for changing our mindset is to focus on movement over exercise. And really, our bodies are designed to move. So I encourage viewers who are resonating with this topic to ask themselves, what gets me moving? All of a sudden, so many options open up. It could be taking the stairs instead of the elevator. It could be taking a 5-minute dance break. It could be just walking down when you're getting the mail down to the end of the block and back. And moving really gets you out of our head and into our body. The second thing that you said is you remember how you felt after your last workout. You know, after we exercise, we feel the sense of accomplishment. We have those endorphins. We feel less stressed, or we even think more clearly and sleep better at night. But we can remember that, those positive, fresh memories that will propel us back to our workout the next day. And then I think, you also talked about it's a habit. And we can make it a habit by setting small goals. Maybe you start with 5 minutes. I've worked with people, and the only goal they had was 3 times a week to walk for 5 minutes. And I've seen them set that goal, feel good about it, they can tolerate it, and then they're able to build up to maybe half an hour 4 times a week, or 20 minutes 5 times a week. Sometimes there's some health issues, like I think of folks with chronic pain that might need to work with a physical therapist or talk with their physician to find a kind of movement that's going to work well for their body. But again, there's so many options out there. And I think it can be fun to have an accountability buddy, whether it's a health care provider or a loved one or family member, even a neighbor, that can keep you at that goal, especially if you fall off, to get you back on track.
You talk about mindfulness. What do you really mean by being mindful?
Well, I think this can be some of the joys of movement. So again, there can be negative connotations of, I have to go to the gym and sweat, and I'm going to compare myself to other people around me, and I'm not going to feel good enough, or I'm going to feel awkward, like I don't know what I'm doing. And all of that is resistance and can take us away from our goal. Instead, we can use some mindfulness to really feel that mind-body connection. And again, if our bodies are made to move, we can use mindfulness. For example, I think 2 different ways. If we're outside walking or biking or jogging, using mindfulness with a 5 senses practice, noticing around us. This is a great time of year with springtime and everything in bloom. We can notice like 5 things that we can see, and then 4 things we can hear, 3 things we can touch, like our socks and our shoes, are maybe a hand touching a leaf, our article of clothing. And then we can do 2 things we can smell. Maybe we stop and smell a flower. And then 1 thing we can taste. So 5 things we can see, 4 things we can hear, like the birds, the wind rustling, 3 things we can touch, 2 things we can taste, 1 thing we can smell. And then the second part is using mindfulness, feeling our body, feeling how it moves. And we might even use that as a practice of appreciation for our body, thanking our body, being aware of the blood pumping, all that's going well in your body, the sensations of exercise, and then just appreciation for how your body's moving and all that your body is doing for you. I think it's important to remember a lot of people can't move in these ways, and even if your body is limited in how it can move, it can still move, and there's joy in that and appreciation for that.
Do you remember reading a piece that you wrote, and you I think you said something like, start with the end in mind?
I think that's wonderful. It's so helpful to have a plan, but even more specifically, a destination. So it can be helpful to train for something. It could be, here in Wisconsin, we have a lot of local walks or runs, maybe to benefit charity. Maybe it's just something, maybe it's could be a trip you're planning for, or maybe just wanting to keep up with the grandkids. That can keep you motivated. So thinking about having a specific goal and then creating a really small but systematic plan. And then you might even have something posted, like a picture of that trip or the registration form for that walk. Again, I think that helps you keep the why to what you're doing day in and day out of getting out there to exercise.
I was thinking about someone I know who has a wedding down the road to the mother of the bride, and she is now in the process of exercising more so she can fit into a smaller size dress.
Exactly. That was an example that came to mind. So I'm so happy you shared that, whether it's, the holiday party and wanting to fit into that suit, or a wedding, or maybe a class reunion, or even just kind of setting a goal, like by the end of the year, I want to feel stronger in my body. I want more energy. I want those pants to fit better. Those are all wonderful motivators.
A listener emailed us, what about exercise advice for those of us with ADHD struggling with being consistent with it?
Well, I think, when we think about the end in mind, exercising regularly is one of the easiest and most effective ways to reduce the symptoms of ADHD. It's found to improve concentration, motivation, memory, and mood, because it boosts those brains, those endorphins. Also, it boosts the brain's dopamine, norepinephrine, and serotonin levels, all affect focus and attention. So I think, keeping that in mind, I think, 1, get it in your calendar. So schedule it. Also think about having the 3 R's, which for behavior change. So the 3 R's, first, having a reminder. Could be that pop-up in your calendar. It could even be your gym bag packed in your car or by the front door so you see it. And you go through the routine, like exercise. So it's reminder, routine. The 3rd R is some sort of reward. Do a little treat for yourself. Like maybe you give yourself, like I think of kids in the sticker chart that gets them motivated to brush their teeth or make their beds. Maybe you say, okay, each time I exercise, I'm going to make a check, and after a week, I'm going to treat myself to something. Probably not food, but maybe you go to a movie, you buy yourself fresh flowers, or you purchase something you've been wanting, or even just do an enjoyable activity that's free. And I think those 3 R's can be really helpful. The reminder, the routine, and then the reward to get us, again, we're forming habits to set goals and that behavior change to help some of these changes stick.
You know, you work with athletes, UW athletes. They devote a lot of their time to training for their sport. How does being so active help or maybe hurt their mental health?
That's a great question. There's so many benefits, right, that we've been talking about. And I did mention overtraining. I think we also have to be careful with our bodies that we're not going all gung-ho with one physical activity. I think of my teen athletes or younger athletes. We often encourage some cross-training, which is really, really important. I also think comparison, there can be at the collegiate level or teen level, a lot of pressure with social media posts and wanting to win the game or how will a mistake be perceived. So we're also working on mindset. And I think this is important for anyone exercising to simply be kind to yourself, celebrate what you can do. And even if maybe you fell short of your goal, that's okay. You can set the goal for tomorrow, and you can always work towards it, maybe slower or modify it, but you can always pick yourself up and get back at it tomorrow.
Some good advice there, Dr. Shilagh. Thank you so much for taking time to be with us today. Really appreciate it. We'll look forward to our next visit. Thank you.
Thank you so much for having me, Larry. It was a real honor to be here.
Dr. Shilagh Mirgain is a distinguished psychologist in the Department of Orthopedics and Rehabilitation at the UW-Madison School of Medicine and Public Health. Always fun to have her stop by, and we'll have her back again, and we'll probably pick up another aspect of her work relating to mental health. Great to have her along. Speaking about health, arthritis comes to mind for a lot of people, and that's what we will be talking about coming up. I'm Larry Mealer for WPR News. Turn our attention now to arthritis. The American Arthritis Foundation says arthritis is the leading cause of disability in the U.S. If you're one of the many who experience pain in your joints, you know that managing your condition is important to everyday life. Larry Mealer here talking about rheumatoid arthritis and osteoarthritis with our guest, Dr. Katherine Finn, with us. She's a board-certified rheumatologist who practices at the Rheumatic Disease Center in Glendale. Dr. Finn is also a member of the Wisconsin Rheumatology Association. As we talk with Dr. Finn, I hope you'll join in. Let us know how arthritis affects your life. Did you develop the pain after an injury, or maybe is aging taking a toll on your joints? You can call us at 800-642-1234. That's 1-800-642-1234. Or you can send an email to talk@wpr.org. That's talk@wpr.org. Dr. Katherine Finn, welcome. Thank you for taking time to be with us today.
Thank you so much. I'm very excited to be here.
Let's talk about the diseases you treat at the Rheumatic Disease Center.
Sure. So where our specialty lies as rheumatologists is really in treating autoimmune-related arthritis, and then we also manage some osteoarthritis as well. So autoimmune arthritis is going to include what you mentioned, rheumatoid arthritis, also includes psoriatic arthritis, lupus, ankylosing spondylitis, which is another form of autoimmune arthritis that affects the low back and sometimes other joints. We treat some rare autoimmune diseases, something called vasculitis, which involves inflammation of the vessels. We treat scleroderma, which is a disease which involves tightening and fibrosis of the skin. And then we treat osteoarthritis, which is a lot more common than all of the ones that I mentioned. We also treat gout. So that is something that comes up quite often and is quite prevalent.
Yeah. So There are lots of forms of arthritis. They're similar, I suppose, in some ways, but you were describing the differences there. It's quite a bit of difference depending on which type you were talking about there.
Exactly. I mean, they certainly can all create a lot of pain and a lot of dysfunction and affect daily activities and daily life. But they are different, and a lot of them are treated differently. When we look at our autoimmune-related arthropathies, actually a lot of the treatment options will sort of work no matter what you have. But those treatment options do not really apply to osteoarthritis. So most of the things that we use for autoimmune arthritis, and we've had all of this advancement in our treatment options, over the past 20 years, so many more options, that unfortunately we haven't seen that same thing happen in osteoarthritis. Hopefully we will see that at some point. The treatments are quite different. When we think about osteoarthritis, the list it's just much shorter, unfortunately, although that affects almost everyone at some point.
Yeah, almost everyone, if not, hopefully not in the younger ages. I mean, do we see it among younger folks? I mean, it's older folks, I'm in that category. I have a little in my hands and so forth, but not bad.
You can see it in younger individuals. If you've had an injury, that is going to probably give you some earlier osteoarthritis. So we think about the primary form of osteoarthritis, which sort of goes along with wear and tear, aging process. But there's things that can kind of speed it along. So one of those things would be injury.
Yeah.
So that could be like a mechanical injury, like ACL tear or whatever. Or we can see earlier osteoarthritis in our patients who also have the inflammatory type of arthritis, because the inflammatory type of arthritis has damaged the joint, and then it wears abnormally, and then you develop osteoarthritis. So we call that secondary osteoarthritis. So usually primary osteoarthritis, 40s and beyond is kind of, I would say, but for secondary osteoarthritis, certainly in some of my younger patients who have had damage, it can happen, yeah.
Yeah, and in fact, Angie in Madison has a question relating to juvenile arthritis, I believe. Angie, are you there?
Yeah, thanks. I was diagnosed with juvenile rheumatoid arthritis when I was about 8 years old, and it went into remission when I was about 12 or 13, and I haven't had any symptoms since, and I'm, very active. And I was just wondering if that usually comes back later in life, and if there's things that people can do to kind of help prevent it from coming back, or is it just kind of luck of the draw?
Yeah, that's a great question. So kids a lot of times have the experience that you had, thankfully, where it goes away. It goes into remission, and it really doesn't come back. And that's the majority of cases of juvenile rheumatoid arthritis, or we now call it juvenile idiopathic arthritis, and there's a few different forms. But if you went into remission at age 12 or 13, I would expect you to stay there. Look, that is an autoimmune condition, so that can give you a little bit of a higher risk of getting some other autoimmune thing later in life. And I do have some patients that do develop something else later, but the vast majority do not. In terms of preventative stuff, I would say the things that I say to everyone: healthy lifestyle, really. Don't smoke. That's a biggie, because we know smoking can really increase your risk of autoimmunity, especially rheumatoid arthritis. Being at a healthy weight, we know that obesity can also increase risk of autoimmune problems, and probably dietary stuff, avoiding the stuff that we all know is not good for us and is inflammatory. So the processed foods and sugars and whatnot. That's kind of my best advice regarding trying to avoid getting another autoimmune condition. I think a lot of it really falls in that lifestyle. But the good news is, I think that the odds are in your favor that you probably won't develop something else.
Angie, thank you very much for calling. Appreciate it. Mary wonders, what is autoimmune?
Sure. So autoimmunity happens when the body creates a self-directed protein. So we call these antibodies, and they can be tested in the blood. Some of our diseases that we treat as rheumatologists, and then there's lots of other kinds of autoimmune diseases involving different organs of the body. Some of them have identifiable antibodies and some do not. But that's kind of the general process by which this happens, is that something happens and it's probably multiple, sort of this multi-hit theory. So maybe some genetic predisposition, maybe an environmental exposure, maybe exposure to a virus or smoking or something, something like that, which then triggers this autoimmunity. So then there's the state of autoimmunity where you have the antibody, and then there's autoimmune disease. So those are two separate things, and I think it's an important point, which is that you can have positive autoantibodies in your blood, but that doesn't always translate into autoimmune disease. So disease is where you actually have the symptoms, right? So you can have like a positive marker for rheumatoid arthritis or a positive marker for lupus, which is called an ANA test, but not actually have the disease. So that's also where lifestyle, perhaps preventative stuff can come in, is in that space where you have some autoimmunity, but you don't have autoimmune disease.
Beth emailed us. She's been having knee pain for a couple of weeks now, can't put her weight on it, mostly right, but some left involvement, and the right hip hurts as well. No injury. X-ray shows mild to moderate arthritis. Right is greater than left. Beth will start physical therapy next week. Anti-inflammatory doesn't help, or doesn't seem to help anyway. Is there a point where Beth should consider systemic disease and go back to a medical doctor?
So I think she's on the right track here in terms of the treatment plan. Sounds like she has mild to moderate arthritis on the X-ray. We have to keep in mind that an X-ray doesn't really tell you what's going on in those other structures. I'm not suggesting that she needs further imaging, but we always keep that in mind. So it's not going to tell you if she had some kind of meniscal problem or a tendon issue or ligament problem. It won't tell that. It'll just tell that she has underlying osteoarthritis, which can certainly cause her symptoms. There doesn't always have to be an inciting incident. Sometimes we get these flares and we're not really sure why it happened. Typically, the things that she mentioned that she's going to be doing are the first step. So we talk about an anti-inflammatory. That can be either oral, so things like ibuprofen, naproxen, if that's appropriate for her. There are some people in whom that kind of medication can cause problems. You can also use topical non-steroidal anti-inflammatories. Voltaren gel, or also called diclofenac, is now available over the counter. And I really like that because it avoids having to take it by mouth. You avoid any chance for gut irritation, and it can really help. So you apply it just to where you're having the issue. So she would put it on her knee, and she could use it up to 4 times a day. And I really like that as sort of another adjunct therapy. Physical therapy often really helps too. So I think give that a fair chance. And if she does the physical therapy, or if it's getting worse, that's when you go back. And sometimes these things, it's just time.
Yeah. Dr. Katherine Finn, our guest today, board-certified rheumatologist. It's great to have her with us. And you can join in, too. Number to call, 800-642-1234, or you can email to talk@wpr.org. What are the red flags that you may have in autoimmune arthritis?
Yeah, so there are a few things that should prompt you to get more evaluation. If you have something that comes on sort of overnight, you feel fine, and then the next day, both both my shoulders and hips hurt. And that goes on. It doesn't go away, and it's been a week or two. That would be something. So this kind of sudden onset, oftentimes if it's bilateral, so if we're seeing it on both sides and it's symmetrical, and again, that you're getting when you could sort of say, geez, this started around this time and I didn't have this problem before. That should also sort of raise a bit of a red flag. The other thing that we'll often see with inflammatory arthritis, which is what I call this autoimmune arthritis, is inflammatory arthritis versus osteoarthritis is more mechanical. So with inflammatory arthritis is morning stiffness. So wake up in the morning and you feel like it's very hard to move. Now that can happen with osteoarthritis or mechanical arthritis, but typically that time frame is going to be less than 30 minutes and less than an hour of morning stiffness. There are exceptions, but typically. So that would be another red flag. If you're having hours of morning stiffness, if you're having swelling in the hands, it's hard to make a fist. It hurts to make a fist. It feels tight. If you're having other systemic symptoms like weight loss, fevers, we can sometimes see. So weight loss is unintentional. Fevers, fatigue, which is out of the ordinary. Those are kind of some general things. There's a lot of little things that when I see my patients for the first time, I generally have people in for an hour because we do a very comprehensive review of systems, we call it. So we talk about, every different kind of symptom to see if there's something else because these are systemic conditions. And so sometimes these little symptoms can be important. But the ones that I just mentioned, I think those are, if I was going to give 5 red flag symptoms, that would be what it is. And these are the ones I generally tell my patients in the office.
Chris called, couldn't stay with us. How could a rheumatologist help Chris with fibromyalgia? And can you talk about the connection between Lyme's disease and joint pain?
Sure. So fibromyalgia is admittedly something that is quite hard to treat. As rheumatologists, we sometimes treat it. It's more often managed by primary care doctors. I think there has, over time, we have gained a greater understanding of perhaps why this disease is happening. So for anyone who doesn't know what fibromyalgia is, so fibromyalgia is this condition that causes widespread pain. So patients have pain in all 4 quadrants of their body on most days of the week. They have a lot of tender points, just light touch is going to hurt. It can come along with other sensitivities, for example, light sensitivity, sound sensitivity, that sort of thing. We'll see it come a lot of times in conjunction with things like an IBS or irritable bowel syndrome. So this condition, I think the way that it really responds best, although I think it's difficult, is sort of these lifestyle things. So patients need to make sure they're getting enough sleep. They need to make sure they're eating well, getting some movement. Movement is key when it comes to this widespread pain. So there have been studies that have been done on some of the medications which are used to treat fibromyalgia. And what they did is they took patients who were taking that treatment and patients who were doing an intervention, which was yoga. And those patients who were doing the yoga consistently had a sustained positive response. As opposed to the patients who took the medication, they had an initial response to the drug, but that kind of waned over time. And we often see that with these drugs, which is why I don't prefer them, because I think they're not durable. We don't get a good durable response from them. A lot of times they sort of, and that's not everyone, right? There are some people who get a good, who get a good response to these, and it does last over time. But I think talking about the lifestyle stuff is really important. So I mentioned sleep, I mentioned diet, movement. Then we want to manage any other health problem that's going on. If there's a thyroid problem going on, we got to manage that. If there's rheumatoid arthritis going on, we need to manage that, because typically if something else is flaring systemically, it's going to cause the fibromyalgia oftentimes to flare up too. So that's something that we need to think about. And then also thinking about just mental health. How is the person feeling overall? Is there depression that's untreated? Is there untreated anxiety, which is leading to other problems like sleep problems and so on? So there's a lot of different pieces to this.
Yeah.
And it's hard. I think it's hard. I think that you've got to have a good primary care doctor, because they can also manage some of these other things, which maybe a sleep study is needed. If you're not having restorative sleep, and you already have a tendency for fibromyalgia, it's probably going to be a problem. So the thing that's being recognized, I think, more is that fibromyalgia is sort of this nerve problem. So it's not really a problem of the muscles or joints. It's more of a problem of nerves. So they're overactive. That's why pain sensitivity to light touch.
I was recalling our conversation of 20 minutes ago when we were talking about the importance of exercise for our mental health. And if your foot hurts or your knee hurts, you can't get the exercise. It can be sort of a recurring thing here, and a system that it's hard to get out of.
Yes, it certainly is a vicious circle. I think the important thing to remember is the exercise doesn't even have to be weight bearing. It could be chair yoga. It could be simple stretches. And that's some of the stuff that is studied in fibromyalgia. It could be water exercise. That one tends to be really, really good. That helps for people who have either a lot of arthritis or fibromyalgia. So fibromyalgia tends to be, you can overdo it. There's this concept of you overdo it. So vigorous exercise is generally not the best for fibromyalgia. It's kind of these slow stretching exercises, light aerobic activity, but water exercise can be very, very therapeutic.
Makes good sense to me. You can join in, too, with your own thoughts or questions with our guest, Dr. Katherine Finn, who is board-certified rheumatologist, practices at the Rheumatic Disease Center in Glendale, Wisconsin. It's great to have her with us today. Peter in Dallas will give you a chance to join in. Hi, Peter.
Hi, Larry. How you doing?
Good. Appreciate the call. What's on your mind?
Well, in terms of osteoarthritis, I've had both knees, both hips replaced. I'm a retired plumber, and now I'm working with my hands, which I've discovered that you can also get osteoarthritis and inflammatory arthritis in your hands. But I was supposed to have surgery in 2020, and with COVID, I just dropped it, and I started doing acupuncture, which has been fantastic. But I've also continued to take meloxicam and then Tylenol 8-hour arthritis, which keeps everything under control. But I've also, my acupuncture suggested a blend of turmeric and fresh ginger with some orange and lemon as an anti-inflammatory, and I'm curious to see what your thoughts are on that.
Great question. Yeah, I'm glad you brought that up. So there's a lot of interest in supplements, vitamins for osteoarthritis. There have been studies that have looked at these things to see how patients respond to them. Turmeric has repeatedly, in well-done randomized controlled trials, shown to be effective for osteoarthritis pain. So I would say go for it. So turmeric, the dosing is typically 500 to 1,000 milligrams daily in these trials, or you could do 1 teaspoon of the spice added into whatever that you're having. It outperformed doing nothing, which when we talk about osteoarthritis, that is important because osteoarthritis consistently in these clinical trials, there will be a 30% placebo response. which is really higher than we see in other conditions. And that is consistent across studies. So when we look at osteoarthritis, you could almost understand why it's hard to get positive trials, right? Because we have this huge placebo effect, which is consistent. But turmeric did beat out that placebo effect and has done so numerous clinical trials. So I do tell my patients about turmeric, and I think it doesn't work for everyone, but I do think that for some people it really helps.
Peter, there you go. And he also mentioned acupuncture.
Yeah, I think we don't have enough data on it, but I don't think it's going to hurt. And I think if you have, so when we think about osteoarthritis, we're really talking about the joint. But there are periarticular, which just means tissues around the joint. So we have muscle, tendon, myofascial, all that stuff that surrounds the joint. And when we have a problem that's going on in the joint, that can lead to other problems that are going on around the joint. And acupuncture, I think, can really help with that aspect of it. So we think about acupuncture or dry needling, working with the myofascial tissues to release them, that sort of thing. It can be a really nice adjunctive therapy. And again, for some people, it really helps.
Peter, thank you so much for calling. Appreciate it very much. We had another listener emailed us who's diagnosed with giant cell arthritis after having a headache on top of the right side of their head. They would love to hear you talk about giant cell arthritis.
Sure. So giant cell, it's actually giant cell arthritis. So it is one of these vascular diseases. So it's an inflammation of the vessels of the scalp. So the temporal artery becomes inflamed. Patients will get temporal artery or temporal pain, like a headache. It will be persistent. It can be one side or both, and will respond beautifully to high-dose steroid. That at this time is sort of the mainstay and has been for years treatment that we use. The exciting thing about this space is that we are having new approvals for medications that can help people get off steroids faster. So as I think most of us know, steroids, look, we love them and we hate them. They work really nicely, predictably, and fast, but they have a whole host of side effects. And so it's hard with some of these really inflammatory diseases that respond to prednisone. Patients get stuck on prednisone for years. So there are new medications that have been approved. There was one that was approved probably 3 or 4 years ago for giant cell arteritis, and that is called Actemra. It's a weekly or biweekly shot that patients can just give themselves. And this is very timely because I think it was just last week, there's another approval for something called upadacitinib, which is a pill, which has been approved also for giant cell arteritis. And that can help us to get patients off prednisone. So the concern with giant cell arteritis is that because we're dealing with vessels that are in close proximity to the eye, we can have optic nerve ischemia, which can lead to blindness. So this is truly something that we take very, very seriously, hence giving 60 milligrams plus at times of steroid. And so it's great to have some other treatment options here that can potentially replace the steroid. Look, right off the bat, steroid is king for this. We still use it, but I think over time and over the next years, that will change.
Yeah, yes, well, that's the hope. Dr. Katherine Finn, our guest today, a board-certified rheumatologist, and she'll be with us right up until 12:30 today. Great to have her along, and you'll be able to join in with your questions as well. I'm Larry Mealer for WPR News.
Coming up on
Larry Mealer here for WPR News, talking about different types of arthritis on the show today. You'll hear how these conditions affect your body, and the options you have for treatment with our guest, Dr. Katherine Finn. She's a board-certified rheumatologist, practices at the Rheumatic Disease Center in Glendale, Wisconsin, also a member of the Wisconsin Rheumatology Association. Our lines are full, so I think we'll just go right to the phones and to Pat in Milwaukee. Pat, thank you for calling.
You're welcome. Aloha, Larry and Dr. Finn, our neighbor. Milwaukee's not far from Glendale. Just wanted to say two comments. The first is the warm water exercise is phenomenal. Osteoarthritis is what I face, as is turmeric and cinnamon in smoothies, in your scrambled eggs, whatever. And on your oatmeal. And then nutrition is extremely important. I go on Wednesdays to the Gerald L. Ignis Indian Health Center on the south side of Milwaukee. And we have a program that combines an hour of exercise plus a nutrition lesson and a main dish, a side, and a dessert that are all diabetic and healthy friendly. And I've made so many of those. They also have a program for diabetes, and everybody in that program over a period of many weeks has lost numerous pounds. And the last thing I will mention is when you go on vacation, if you have osteoarthritis, you might expect the unexpected. Trip to Croatia, day number 4, broke both legs. Tibia was so shattered that it looked like a box of broken toothpicks in the x-ray. And I'm still using my cane. And this happened, I was in the Dubrovnik Orthopedic Trauma Hospital October 7th through 13th of 2023, and I'm still using a cane.
Oh, I'm sorry to hear that,
gosh.
Pat. Very sorry to hear that. But her other comments, I think, were about water therapy and nutrition were spot on.
Yeah, I think those were really great points. Thank you, Pat. It's always good to hear it from someone who's done it and who can speak for it, because I do think some of these things really help. And just to speak to her unfortunate fracture that she had, so fractures, while I don't know what her fracture resulted from, there is another condition of the bones, which is called osteoporosis, or osteopenia, which can lead to the fractures. Now, of course, those who have arthritis may have mobility issues, and so that may lead to a fall, and then that can lead to a fracture. So that there are some connections there. But it's actually a different issue.
Yeah, a different issue. But, Pat, I'm sorry for the accident and appreciate your call and your comments very much. Kim in Eau Claire will go to you. Hi, Kim.
Hello, Larry. Hello, doctor. I was calling. I've got gout, and I'm on 300 milligrams of allopurinol. I was wondering, because my uric acid levels are still very high, how much damage am I still doing to my joints?
Good question. Well, how high is your uric acid? Do you know?
No, I don't know offhand.
You don't know? Okay. So then I'll give you some kind of generalism. So typically we want your uric acid to be less than 6. So if you're more than 6, you're at a more increased risk of having flares of your gout, and flares can lead to joint damage. Are you having a lot of flares?
No, I haven't had a flare in I don't know how many years. I just read an article. I guess the reason I read an article stating that the crystals are still there, even though you're not having attacks, and they're damaging your joints because of the high uric acid.
Sure, I can speak to that. Yeah. So gout is a crystal arthritis, just as you said. And what happens is the crystals come out of solution and they precipitate in and around the joint and create this massive inflammatory response. What they can also do is form what's called tophi, which are sort of a ball of the uric acid crystals, which can damage the joint. They can cause these big erosions in the joints, which can be pretty dramatic looking. So over time, if you take allopurinol at the appropriate dose that is getting your uric acid to less than 6, these deposits of uric acid crystals can dissolve. They can go away. It takes a while, but that can happen. In more severe cases of gout, which we call tophaceous gout, this is where we can actually see the gouty crystals deposited in the soft tissue and around the joint. It's visible on exam. For some of these patients, there's another treatment, and probably another one that will be coming, which can more rapidly dissolve these gout crystals. It's not for everyone, but for some patients, it really, really helps. So I think it depends on what the caller's uric acid is, whether he, has ongoing chronic inflammation, because that's really our marker for this, for gout. The marker for gout is that uric acid. That's how we can kind of know if the joints are quiet and if we're reducing your risk of having flares.
Kim, thank you very much for calling. Appreciate your call. Gary in Milwaukee, it's your turn. Hi, Gary.
Well, hello. I have a question about vasculitis. I know this program is mostly about arthritis, but I was hit with a case of vasculitis almost exactly 3 years ago, and it was intense. I survived and I came out of it, and it's been in remission now for over 2 years. But the damage that it caused still gives me pain. And I take gabapentin, which I know it works because every so often I try to back off of it and I got to go back on. I don't take much, 600 milligrams a day. But I heard you mention earlier, I recall when I was on steroids, the steroids are very effective, but I know you can't stay on them forever. Earlier you mentioned a medication that was used in place of steroid. I'd be curious about that. And I'd also be curious about any opinion you have about ways to mitigate this remaining pain from the damage. That is the biggest problem now. And I also want to make a comment, too. My doctors have taken very good care of me, but nobody has ever expressed any interest in why this happened. I mean, I know there must have been something in the environment or whatever that caused this because it hit so hard and so fast, and nobody has ever really said, well, it happened because of this, that, or the other thing. And I'm curious to know what you say about that. Your office is only about 2 miles away from where I live, and I'll be glad to make an appointment.
So first I would ask you, Gary, what kind of vasculitis did you have?
I've heard the terminology a couple of times. I will give you the consequence of getting it. I was hit hard, ended up in a coma for 6 days, in the hospital for a month. I have nerve damage in both feet and my left hand. I lost 30 inches of my small intestine, and this all happened in an instant. And I don't know exactly what I do know that the tests they give me are for ANCA-C and myeloproliferative.
Okay, that's what I was thinking. Okay, so and it sounds like you went into remission, which is great. Did you got Rituxan, I'm assuming?
Yes, I did. I started out with cyclotoxin, but then I went to Rituxan, and I haven't had an infusion of that for about 1.5 years now. Okay.
So for everyone, ANCA vasculitis is a small vessel vasculitis, which can affect multiple different organ systems. So where you have a small vessel, just about, it can affect that. So it commonly will cause nerve damage. And it sounds like that is what you are suffering from. Nerve damage is difficult because nerves are just difficult. They can be damaged, and then even though the insult is gone, the inflammation is gone, the pain and symptoms may continue. That's where your gabapentin comes in because that is directed at nerve pain. It's not an anti-inflammatory. It sounds like your doctors think you are in remission. So prednisone or some of these other medications which are approved for vasculitis, and that's actually a different kind of vasculitis. Not to say that we may not be using those for what you had in the future, but those are a little bit different. But I think it sounds like your problems are due to the sequela of prior inflammation. So I think gabapentin's a great choice. Admittedly, it's hard to treat these nerve problems. We think about diabetic neuropathy, we think about ongoing pain from having shingles. It can be really debilitating and really difficult to treat. So I don't think steroids necessarily would have a place here, but I'm just kind of going by what you're telling me and without the full information. And then when you asked about cause of vasculitis, probably no one gave you an answer because we just don't know. We just don't know. Just like other forms of autoimmunity, because this is an autoimmune disease, maybe genetics play a role here. Not that you have to have a relative with an autoimmune disease, but we do see that happen. Environmental factors, viruses can be a trigger, maybe some kind of other environmental exposure. We don't really know. We don't really know. It's probably multi-hit, like I was saying before, it's not just one thing. More than one thing has to go wrong for the immune system to go a little wacky. Same thing with cancer, right? Cancer is also immune regulated. It's different, but same concept where it's probably multiple things have to go wrong in order for a cancer to develop or an autoimmune disease to develop. Stress is a factor too, which I didn't mention before, but I think it's a trigger. I think you probably already have some of these other risk factors going on, and then stress is a trigger. I hear this a lot. I had a stressful event, a family member was ill or something at work or whatever it might be, and then the next month I started getting these symptoms. I hear that a lot.
Gary, thank you very much for calling. Appreciate your call. And go ahead and make your appointment. There you go, Gary. Thanks very much. Appreciate your call. Teresa in Appleton, your turn. Hi, Teresa.
Hi, good morning. Thank you for taking the call. I love everything I've been listening to so far, and I lost an aunt to rheumatoid arthritis at 70, and I myself had been diagnosed with everything under the sun in the autoimmune area, and they just landed on undifferentiated connective tissue disorder. I was on methotrexate, and I was told I'd be on it for life. But in working with, like you said, sleep, stress, exercise, but mainly the microbiome and adjusting my diet, I've worked off of those medicines for several years now and have been maintaining lack of flare-ups, like no flares. And so I'm wondering, in your practice, how much more are you hearing about microbiome? How much more are you looking at microbiome and its impact on all inflammation diseases?
Great question. Thank you for that. I think the answer is it certainly plays a role. We don't know exactly. I keep saying that a lot. We don't know. It's true. We just don't know exactly how it fits in and how it's different in each individual. So, for example, I wouldn't be able to tell you a diet which suits your exact microbiome because everyone is a little bit different. I can tell you that it's being studied, and there are positive studies in our autoimmune patients where we see an altered microbiome, an altered gut microbiome in patients who have an autoimmune arthritis versus those who don't, a healthy control. So there is something going on here. And it makes sense, right? I definitely see it in clinical practice where people change their diet, clean up their diet, take some things out, eliminate things, or simply eat cleaner, and they're better. They're better. So, and I think the other part of this is just metabolic health. It certainly plays a role here. There will be a lot more to come on this because of the prevalence of GLP-1s, Ozempic, tirzepatide, etc. A lot of our patients who have autoimmune diseases are taking these medications and having a positive response. So I don't have any real data for this, but we see people get better. Is it just from weight loss? Is it from a general, decrease in inflammation, from other reasons other than the weight loss? What is it exactly? Does it have to do with the gut microbiome? I don't know, but it's an important piece. And I hope that our research keeps going in that direction, because that's sort of this root cause medicine. If we can really get at what's actually going wrong here, we can help for all our treatments to work better. Or maybe in some select people, they won't need it anymore. And, when we talk about this undifferentiated connective tissue disease, yeah, it sort of falls in this class where patients can have multiple different autoimmune symptoms, but they don't necessarily meet criteria for one particular disease, say lupus or rheumatoid arthritis. And so that's sort of what we call it. At the end of the day, we treat based on what symptoms are present. So it almost doesn't matter a whole lot what the label is, because we treat the symptoms. So that's why methotrexate, totally appropriate for joint-related symptoms. That's one of our go-to medications. But I think, across the board, improvement in lifestyle, in diet, I've seen it really, really help people.
Yeah. Teresa, thank you so much for calling. Appreciate it very much. Madeline in De Pere will give you a chance to join in. Hi, Madeline.
Hello. I was diagnosed with pseudogout. What's the difference between regular gout and pseudogout, and how do they test for that acid level? How do they test for that?
Great question. Thank you, Madeline. So pseudogout is kind of a cousin of gout. It is another crystal disease, but it has nothing to do with uric acid. It's actually a crystal deposition of something called calcium pyrophosphate. We also call it CPPD, or calcium pyrophosphate deposition disease. This can present exactly the same as gout: an intensely swollen, painful, red-hot joint. It can be in the big toe just like gout, and so painful you can't put a shoe on it. It can be mistaken for a fracture. I mean, it's intensely painful. So there's a few different forms. There's one which is called acute pseudogout. So that's when you get this flare, which looks like a gout flare. It's typically treated with nonsteroidals like ibuprofen, Aleve naproxen, sometimes some prednisone, sometimes colchicine, which is another anti-inflammatory. Then there's another form of pseudogout, which is more chronic. It can look like other forms of autoimmune arthritis. This is not an autoimmune arthritis, though. It can look like rheumatoid, or it can look like another inflammatory arthritis, in that you have chronic swelling. It often happens in the wrists. And the way that we diagnose this is based on x-rays, some blood work, because we would check a uric acid, and aspirating the joint, sticking a needle in the joint if it's swollen, get some fluid out. We put it on a slide and put it under the microscope, and we can see these rhomboid-shaped crystals. When we look at a gout crystal, it's shaped like a spindle, or like a, like a needle. It's a needle.
Okay.
As opposed to the rhomboid shape. So when we talk about treating pseudogout, chronic pseudogout, anti-inflammatories is still kind of where it's at with this. Sometimes we'll try more advanced treatments, but also important point, pseudogout has nothing to do with the diet. It has nothing to do with the diet. It goes along with osteoarthritis. Those two are heavily linked. Sometimes if your magnesium levels are low, it can give you increased chance of pseudogout. If you've had damage in a joint, pseudogout likes to form there. But it's a different crystal disease.
Madeline, thank you so much for calling. Appreciate it. Greg from Madison emailed us. He has pain on his wrists. He thought it was from working on a computer for 30 years. At first, he assumed it would be carpal tunnel, but it's traveled to his wrist, to the base of his thumbs. He thought it could be something like arthritis or even delayed reaction to Lyme disease that he contracted in 2021. Any suggestions?
Did he say if this is just one wrist or both?
He said both.
He said both. Okay. So, and not knowing a lot about how old he is, etc., pain at the base of the thumb is usually osteoarthritis. That's really common to get at the base of the thumb, and you can understand why, because it's a very used joint.
Yeah.
So that's my first thought on this. If it's truly the wrist, and so that would be more in the middle as opposed to the base of the thumb, that could be, that kind of broadens the differential a little bit, if you will. But from just hearing base of the thumb, it sounds like osteoarthritis. He can try some Voltaren gel. I really like that for this. He could use some immobilization, a spica splint. You can buy these online on Amazon. They're like $10. Wear it at nighttime. Put some Voltaren gel on first. Wear it at night. Just immobilize it. And if it still persists, an X-ray. Go see his primary care. Get an X-ray.
And I guess it started at his wrist and then went to his thumbs.
Oh, it started at the wrist into the thumb. It's hard to say because sometimes when you have arthritis at the base of the thumb, it kind of, because it's adjacent to the wrist, right? So it can be a little tricky to tell that apart. Getting an X-ray is not wrong here because he could have something, he could have a ligament problem in the wrist that can cause swelling. So I think that would help.
Yeah, it makes a lot of sense. Boy, we've covered a whole lot here today, and I still have 20 questions that I could ask you, Dr. Finn, but I want to thank you so much for taking time to be with us today. I learned a lot, and I think our listeners did as well. And will you come back and be with us again? Love to have you back.
I sure would. It was an honor to be here. Thank you for inviting me.
Dr. Katherine Finn, our guest, board-certified rheumatologist, practices at the Rheumatic Disease Center in Glendale, Wisconsin. She's also a member of the Wisconsin Rheumatology Association, and we'll get her back and talk again. I'm sorry we didn't get to everybody, but that's kind of the way it works around here. Coming up, we're going to turn our attention to your skin and talk about skin care as we get from spring and then on into summer. Dr. Apple Bodemer next. I'm Larry Mealer.
You're gonna need an ocean of calamine lotion. You'll be scratching like a hound the minute you start to mess around. Poison ivy.
Poison ivy by the Coasters. And if you're unlucky, you might run into that pesky plant this spring and summer. Our next guest has some tips for treating that itchy rash and a whole lot more. Larry Mealer here talking about skincare with our guest back with us once again, Dr. Apple Bodemer. Dr. Apple is a dermatologist, professor in the Department of Dermatology at UW-Madison. She also directs an integrative dermatology clinic, which focuses on offering this healthcare approach for dermatologic conditions. And as we talk with her, want to hear from you. Let us know what ails your skin this spring or summer. What do you want to know about taking care of bug bites, maybe? Give us a call. The number's 800-642-1234, or you could send an email to talk@wpr.org. Dr. Apple Bodemer, welcome back. Good to have you with us.
It's good to be here, Larry.
You're talking about poison ivy and poison oak there from the Coasters, but how can you tell if you've got a rash from poison ivy or poison oak?
Well, usually it's very red and kind of swollen, and then it'll start to blister up for most people. It's intensely itchy. So if that happens, if you notice, especially in an area where you might have been exposed to some plant material, then you should consider that might be the case.
Yeah. Are there ways to prevent it from spreading, the rash?
Yeah, so it's actually caused by an oil called urushiol, and that oil is found in poison ivy, also in poison oak and poison sumac. And once that oil is on the skin, it can spread on the surface of the skin by rubbing or scratching. It can also transfer from clothing to the skin or even from animals. If you've got, a dog that might be running around in the woods, and then that oil gets on the dog's fur, it probably won't cause the dog too much trouble. But if you are petting the dog and you get a rash, that could be poison ivy. So something just to think about.
Yeah. How do we relieve the itching and the pain?
Well, first of all, you want to wash it off. And because it's an oil, you'll need to use soap and warm to hot water. If you just are kind of using cool water and kind of rinsing, the oil will just sort of spread on the surface of the skin or clothing or whatever it is you're trying to get it off of. So really important to wash the skin as soon as you can. So if you are somebody that works out in the woods or in a place where there might be one of those poison ivy, poison oak, or poison sumac, then you'll want to just make sure you clean yourself really well. Wear protective clothing. So wearing long pants, long sleeves, tucking your pant legs in, kind of all the things that we do to protect against ticks can also help us protect against having our skin get exposed to poison ivy.
Yeah. And I'm wondering about washing the clothes.
Yeah. Yes. And that should be, you should wash clothes, especially if you know you've gotten poison ivy. The clothes that you are wearing should be washed with, detergent and as hot a water as that clothing will tolerate.
Yeah. And what might a doctor prescribe to help treat a rash gone wild?
Well, if it's really bad and you end up in, say, urgent care or in your primary care doctor's office or your dermatologist's office, then you'll probably be getting prescribed something called prednisone, which is an oral medication that can just cut down the inflammation and give people relief pretty quickly. That usually needs to be taken for about 2.5 to 3 weeks. If you stop it too soon, the rash can flare back up again. Even if it's kind of gone away within a few days, we commonly will see that. But there are some things that you can do at home before it gets to that point. So if your case is mild or you're catching it early, things like calamine will help dry up some of those blisters, like a calamine lotion or hydrocortisone 1% cream or ointment, which you can get over the counter, or 0.5% is also available. That can kind of act as a mild anti-inflammatory too. Cool compresses or oatmeal baths can be really soothing. They're not really going to take the rash away, but they can help make it more tolerable as you're going through it.
Dave in Appleton has a question for us. Let's go there. Hi, Dave.
Hi, thanks for taking my call. I don't know if this question is appropriate for this program. However, I do get bruising under the skin very easily, and I'm told that it's purpura or something, very thin blood vessels that burst easily. And my main question is, why am I getting it now? I never had it before. Is it age? I know people in my same age group that don't get it, same diet. How can I take care of that and prevent it?
Yeah. That is, we call it solar purpura, and it's usually due to the thinning of the skin and the blood vessels, as you already mentioned. And the biggest driver of that really is UV exposure or sun exposure. And so while your friends might be the same age, they maybe haven't had the same level of exposure. The other thing is things can thin the skin out. Other things that can thin the skin out, like people who are on prednisone for long periods of time, that can also cause the skin and the blood vessels to get thinner, and that might contribute. But the best thing that you can do is try to slow it down, try to slow down that thinning of the skin. So wearing protective clothing, like a UV protective sleeve on your arms, or sunscreen. Sunscreens have, they're not perfect either. They rub off and they wear off. So I'm really a big fan of those sleeves. And then trying to protect your arms from any trauma. And I know lots of people get to the point where you kind of look at a doorknob and think about bumping it and the bruise shows up. So it's not always possible because it doesn't always take a lot of damage or trauma to cause the bruising. But really, that's kind of the best thing that you can do is to try to protect it from further thinning through UV protection. There's some people that think arnica helps bruises resolve more quickly, and so there are several different arnica creams on the market that you could give a try. I don't know if they make a big enough difference to matter clinically, so I'll tell people it's safe as long as the skin isn't broken. But if you've actually broken the skin, you don't want to put arnica on that broken skin.
All right. Dave, thank you very much for calling. You can join in too at 800 642-1234, or you could email to talk@wpr.org. Well, besides poison plants, what are some other common rashes you see pop up as the weather gets warmer?
I mean, bug bites are a big one, and people have different reactions to different types of bugs, and they can be really itchy and really problematic. Mosquitoes are probably the biggest one here in Wisconsin because they're so common and they're such a nuisance. And some people react differently than others. So the reaction that we have from a mosquito bite is actually our immune system reacting against compounds that are in the mosquito's saliva. And we'll have different ways that people will react to that differently. And some people are more attractive to mosquitoes than others. So, some people might get a few bites over the summer and not have too much else. And then others will get just ravished by the mosquitoes, all summer long.
Yeah, I'm one of those.
Yeah. I like going on hikes with people like you because I don't get bites.
Oh, man. Sometimes these springtime allergies will cause somebody to break out into hives. How do you tell if a rash is hives?
So hives, and usually like springtime allergies, usually those are more upper respiratory conjunctive, like your eyes get red and itchy, or you have a lot of congestion or sneezing. That's usually the way kind of the pollen or the other types of seasonal allergies work. But people can get hives from a variety of things, including temperature. Some people can get cold-induced urticaria, is what we call it. Urticaria is the technical term for hives. But you have hives if you get itchy, sort of red, smooth plaques. So they're usually kind of flat top. It's not like a bump that has a rounded surface always. Sometimes they do, but they'll move around. So typically hives will show up and then they'll disappear within 24 hours in that location, but then you'll get new spots in different places. So this kind of moving around and being very itchy, that's sort of the giveaway for hives.
There are a couple of places where I'm driving. There's one place just south of Eau Claire, about 15 miles or so, and I'm driving through that area pretty much every time. It feels like my eyes just start to completely water. It's almost a dangerous thing because I'm trying to, my eyes turn red, they start to water. And I've often wondered what in the heck could be causing it. And it's always in that same spot.
Yeah, there must be some plant there, and I don't know what it would be. It's often hard to kind of pinpoint exactly what it is that's causing kind of these seasonal type allergy symptoms or even hives. But antihistamines, maybe you want to have some antihistamine on hand when you drive through that specific spot.
And it's usually probably the same times of the year that I'm driving through that spot, too. So, yeah. Well, as you garden or work outside, you can get really sweaty. How healthy is it for our skin to sweat?
Well, sweating is, we do it mostly for temperature regulation. So it helps keep us cool, or helps kind of allows our kind of body to maintain a good core temperature. And so it's a good thing to sweat because it tells us that your body is working to regulate its temperature. When people don't sweat, they can have really big problems. Sweat can be problematic for some people, however, especially if you have eczema. Sweat can really irritate the skin. And so that's something that we kind of usually will see that sunlight, a little bit of sunlight can sometimes make people's eczema get a little bit better. But if you're somebody who's sweat sensitive, it can be really uncomfortable and cause actually more than just itching on the skin, but it can even cause some pain.
Someone else just emailed in, could you repeat the herb that helps with the bruising of the skin? And if you wear sunscreen clothes, will your skin get thicker again?
The skin will probably not get thicker again. So it's really to prevent the whole process from progressing or getting worse. And that cream is Arnica, Arnica.
Arnica. Okay, let's go to John in Spooner. Hi, John.
Hi, how you doing?
Good. Appreciate the call. What can we do for you?
Thanks for having me on. I'm a daily listener. I heard a bit ago a caller called in about poison ivy, and there was some conversation about that. So I'm extremely allergic to poison ivy, and I went to doctor, dermatologist, and got all the pills and everything. Nothing worked, and so it was on the East Coast. The humidity in the air carries the oils, so I don't even have to be in contact with it, just the oil in the humid air. So I'm covered from head to toe every summer out there. But I ran across in a book that vitamin C with rose hips. So if you take that orally, like a 250 milligram four times a day is the best, lower dose. But it's got to be with rose hips. And the other thing is, if you take the vitamin pill, crush it between 2 spoons, and put that wherever the rashes broke out. So I did that. Well, the vitamin C burns just like a lit match for about 10 seconds, and then you don't have no more itching, no more. And within 3 days, there's no sign I ever had poison ivy. But after going to the doctor and spending tons of money and weeks went by, it didn't change. It just kept getting worse. And then I also told another friend with the same situation. He waited about 3 weeks. Finally, he went and got the vitamin C, and that cured it. Same thing, 3 days. Friday, he started taking it. By Monday, he came back to work. Not a sign he ever had it.
Vitamin C with rose hips.
Yeah. Yeah, I do know that this rash, it usually will burn out within about 3 weeks. So even if you don't treat it, because, in terms of medically treating it, it will get better on its own. It just takes some time. So I don't know in terms of the mechanism that vitamin C would cause specifically the rash to go away. But, it's really good for your immune system in general. So maybe it's working some way kind of in that mechanism.
It could well be. John, thank you so much for calling. Again, you can join in. The number's 800-642-1234 or email to talk@wpr.org. Dr. Apple Bodemer, our guest today, dermatologist and professor in the Department of Dermatology at UW-Madison. I'm Larry Mealer. Talking with Dr. Apple Bodemer, taking a look at your skin today. She's a dermatologist, professor in the Department of Dermatology at UW-Madison. And again, join in 800-642-1234 or email to talk@wpr.org. Michelle emailed us. She has rosacea and is struggling with her face, always being severely dry and hot and burning. Is there anything she can do to help cool the burning without drying out her skin and making it worse?
Yeah, that's tough. And it sounds like if she's that uncomfortable, she might want to reach out to a dermatologist, because there are some medicated creams that can help slow the progression or help slow rosacea from getting worse. One of the biggest drivers of rosacea and rosacea flares is UV radiation exposure, so sunlight exposure. And so usually with people, especially with that dry kind of burning type of rosacea, they tend to be sensitive to a lot of chemicals that we find in personal care products. And so I generally recommend getting a really good quality mineral-based sunscreen. Finding one that's formulated for babies can be helpful, and because it's going to be less irritating in general than others that are formulated just for regular people, or one that's hypoallergenic. And there are several on the market out there, but also the big hats, sunglasses with wide lenses, try to protect that skin from UV radiation, because that will make the rosacea get worse.
What about athlete's foot? What's happening to the skin when that develops?
So athlete's foot is a superficial fungal infection of the skin. And this fungus lives everywhere. People might get grossed out and think, that it's a sign of being dirty. It's not. This fungus, you'll find it in gyms, in pools, like anywhere where people are, you'll find these types of fungus that likes to live on the skin. And it can show up, and in summer a lot of times it's because we're wearing flip-flops or sandals, or maybe going barefoot in public places. It's easier for us to pick up that fungus. It especially likes warm, moist environments like a pool. The showers, in a pool, and if you're going to a public pool, they're always like going all day long, so they don't really get a chance to dry out in between. So wearing flip-flops in public places where you might otherwise go barefoot can really be helpful, at least in decreasing the chances that you're going to pick it up.
That makes a lot of sense. Lisa in Berlin has something. Let's go there. Hi, Lisa.
Hi. So I'm calling because, like, during the summertime.
Oh, she has. I saw a part of it. She has acne gets acne in the summertime on her face and on the backs of her legs, I believe.
Okay. Yeah. Well, there's a lot of different ways that acne can show up, and it's usually not showing up on the back of the legs. So there might be something we call folliculitis that's going on the back of the legs. And, I would want a little more detail in order to give any more specific recommendations. A lot of people experience acne as getting better in the summer because the UV does kind of help shut down a little bit of the inflammation. And so a lot of people say, well, it gets better in the summer. So if hers is getting worse in the summer, I would wonder if it could be in this folliculitis category, or maybe what's going on in the face could be in the rosacea category.
Katherine in Baraboo, on to you now. Hi, Katherine.
Hi, Larry. I just was listening to you as I was driving to do errands, and I'm pulled over and safe now. But I just wanted to bring up that sometimes medicines that we're taking for one thing or another can also cause rashes. I had thought that I had just a sun sensitivity for a number of years, and did all of the staying out of the sun sorts of things, which I do anyway because I'm fair-skinned. But I had been taking a drug called hydrochlorothiazide for my blood pressure, and I was able to stop that due to my blood pressure being under good control even without it. And I now can be out in the sun, and I no longer get an itchy, bumpy rash. So, hadn't really been thinking about that as a cause, and my doc really hadn't either until sort of serendipitously, I didn't have to take it anymore. So.
Yeah, Katherine, thanks. Yeah. Comment on that, Dr. Apple?
Yeah, there are a number of drugs that are known to cause photosensitivity, is what we call it. So these photosensitizing drugs, and hydrochlorothiazide is one. So sun sensitivity is one type of rash that medications can cause. There are other types of rashes that medications can cause as well. And, one of the things that we like to say is any drug can cause any reaction. And that's not totally true. Some drugs are more likely to cause certain types of reactions. But if you start a new drug and you start having new problems with your skin, it might be something you want to check in with either the doctor who prescribed it, your primary doctor, or a dermatologist.
Yeah. Chris in Madison, your turn. Hi, Chris.
Hi, how are you?
Good. Appreciate the call. What's on your mind?
Well, I just heard a lady talk about the fact that she had rosacea and she couldn't find any kind of skin care that might help, and also anything to cool her face off. And I just wanted to say that I literally go online and just put in rosacea care, and that's the name of the products. And they have a full line of cooling sprays and skin moisturizers, and it's all made from natural products. I believe it might be out of Europe, actually, but you can get it here in the States. That's the only reason I'm calling.
Rosacea care. Are you familiar with that, Dr. Apple?
I'm not familiar with that particular line. There's a lot in the skincare market out there. And, I think I'm a big fan of plant-based oils for people who have rosacea as moisturizers, because they usually, especially if they're the kind of dry and burning type, they can tolerate a little bit of oil on their skin, and then there's nothing else in it. I also really like the cooling sprays, and even just keeping a water bottle filled with some just regular tap water near you, so that if your face does start to feeling hot, you can kind of spritz your face, especially if you're exercising, because we all get red and hot when we exercise. And with rosacea, they tend to get redder, hotter, and then they stay red and hot a longer time. And so finding ways to cool the skin down throughout the day when those kind of flares pop up can be really helpful.
Yeah. What about heat rash? Let's talk about that for a minute. What causes a heat rash?
Well, there's a couple of different things that kind of get lumped under heat rash. The most common is where your skin gets hot and it's stuck against something else. And so the sweat glands can't release the sweat onto the surface of the skin, and it kind of starts to build up underneath the skin. And then people will get these tiny little white dots all over whatever surface that was. So we can see that, especially if people are hospital-ridden or bed-ridden and they're like lying in a warm environment, they can get this, we call it miliaria crystallina, which is a fancy name for it, but it's a form of heat rash. And so that's one form of heat rash. The other, like there are also types of allergies. People can have allergies to the sun, to different wavelengths of sun, and so that's something that can happen. And then there's another more common thing called polymorphous light eruption, or PMLE. And with that, it's polymorphous because it can look really different in different people. But that usually shows up in the spring when people will end up with these itchy rashes in the areas that are exposed to the sun, at least initially. And then over the summer, as they continue to get some sun exposure, the skin does something that we call hardening, which is kind of a misnomer. The skin doesn't actually get hardened, but it gets used to the UV exposure, and it doesn't react quite as intensely. So that kind of spring heat rash is what might be a clue that you've got the polymorphous light eruption happening.
And what about sunscreens? What are you recommending? I know you like to cover up, and, clothing and, large hats and all that are a big help. But if you're going to use a sunscreen.
Yeah, there's a lot of controversy around, especially the chemical ingredients, active ingredients in sunscreens. And what we found in the last couple of years, the FDA did a study and found that we were absorbing these chemicals to a much higher degree than we thought we were. And so I generally recommend staying away from those chemical ingredients. So when you get a bottle of sunscreen, you want to turn it over to the back, and it'll have a list of active ingredients. And it should say zinc oxide, titanium dioxide, and or iron oxide. So those are the three physical blockers that are going to be safer for your skin and also less likely to cause allergic reactions, because that's another thing that can happen with people can develop allergies to the chemicals in sunscreens. And so that's generally what I recommend. If you have sensitive skin, look for one that's either hypoallergenic or formulated for babies. And then there's a lot of variability in terms of thickness or lightness. What does it feel like on your skin? Is it one that has some tint to it, that it kind of acts like a makeup type, concealer type thing? And if you're somebody that wears makeup, usually those are really easy to use. But if you're not, you might not like that tint. So you kind of want to play around and find something that works for you.
And one final quick one here, blisters. You wear sandals. I don't wear them because I always get a blister. How do you heal a blister as quickly as possible?
Well, keep it covered, keep it clean, try not to pop it. And if you find yourself that it's really painful and you need to pop it, you'll want to use a sterile instrument, whether that's like something that's been sterilized so that you don't introduce infection into the blister. Best to leave the surface on. So it's easy to want to peel those blisters off, but that blister surface acts like kind of a natural Band-Aid and a natural healing environment for the raw skin underneath. So those are just some like quick tips. There's lots of those friction blisters like you're talking about are really common, but there are other reasons that people can get blisters. So if they're finding that they're getting blisters in places where they don't have friction or they can't quite explain it, it might be an important thing to bring up with your doctor.
Always a pleasure, Apple. Thank you so much for taking some time to be with us today, and we'll look forward to your next visit. Thank you so much.
Thanks so much for having me.
Dr. Apple Bodemer, dermatologist and professor in the Department of Dermatology at UW-Madison. Lots of good health information on the show today. A big thanks to our team. It's a team effort. Clara Neipert, Joel Patnaud, technical directors, and Lee Rayburn and Jeff Robbins are our technical directors. Clara and Joel are our producers, of course. And Jill Nadeau is our executive producer. I'm Larry Mealer. Thanks for listening. Stay with us. Lots more in store here on WPR News.
Calamine lotion, you'll be scratching like a hound the minute you start to mess around. Poison